right, so now we're moving on to specific shocks like hypovolemic shocks. And no, we're not like, is it this one? It could be increased CVP. Is it this one? It could be increased wedge pressure. If it's this one, it could be, don't give antibiotics. And so now we're going to kind of be a little a little more fine-tuned with hypovolemic shock for a little bit, because when you get to cardiogenic shock, then you're back to where you're adjusting things back and forth, right? But hypovolemic shock is very, very cut and dry. It's either you lost volume or you lost blood. It's one of the two. All right, it's very, very straightforward. It doesn't require a lot of thinking. It says, oh, you're losing blood. Let me replace it. Right? Oh, look, you have lost a lot of volume. Let me replace your volume. Okay. So, of course, making sure we are protocolized so we can recognize that someone is getting tachycardic and their shock index is going up, and they are, they lost a lot of fluid. They are very, very dehydrated on exam. That can clue us in that they have hypovolemic shock. On the flip side, if they're hemorrhaging, obviously they are hemorrhaging. If they're a trauma situation, right? They're hemorrhaging blood. It's going to trigger the whole cascade just like before, right? We're going to have low blood pressure. The SNS is going to fire off. We're going to have the RAS fire off. We're going to have the ADH fire off as well. All these things are going to trigger, and we're going to see the same symptoms. We're going to see them trying to vasoconstrict to try to restore blood volume, and they're also going to be, your heart rate's going to be elevated, right? There's not a situation, well, I guess I could take that back. If you're losing a lot of blood really quick, you might get bradycardic because you lost that blood flow to your coronaries. But 99% of the time, you are tachycardic. You have the classic picture of someone that when you hear someone's in shock, this is like the shock that you hear about. All right, so what are your causes of shock, right? So they lost volume. They probably lost it because they had nausea, vomiting, diarrhea, right? They got GI losses. They have a short gut syndrome, which is a little more rare situation, but they are losing volume out their gut, whether they are vomiting it or they have diarrhea. And then they have excessive diuresis. So not diaphoresis, which is also a reason, but they have excessive diuresis, right? They are peeing out so much volume, right? It could be our fault. We gave them too many diuretics, right? Or it could be diabetes insipidus, right? Where you're DI, you are dry inside because you are peeing out so much volume. Your ADH isn't working, right? You're either not being released or your kidneys aren't responding to it, right? So that's diabetes insipidus. And excessive diaphoresis due to heat, right? And then we got our diabetic complications, DKA and HHS. We'll touch base on these more with endocrine, but DKA, you have polyuria, right? And they have very increased thirst as well, polydipsia. So they're polyuric. They are peeing out a lot of volume because where sodium goes, water goes, and where glucose goes, water goes. They have this hyperglycemia situation in both DKA and HHS. Which is more dehydrating, HHS or DKA? HHS, right? So DK is about 4 liters, 6 liters deficit of fluid that they lost, whereas a HHS patient is 8 to 12 minimum that they lost. They lost almost double the amount of a DK patient. So they're severely dehydrated. And burn patients, right? Your skin keeps you from evaporating all the fluid in your body. And if you burn off your skin, you lost that ability to stop evaporation. So they're a high risk of losing volume as well. Third spacing, especially in SIRS or low albumin states, could cause some hypovolemia. And then what else? So iatrogenic, so post-dialysis, we took off too much fluid and now they're hypotensive. Well, let me give a little 500 cc's back and might give them some albumin to help out, hold them over. Might have to give them pressors in the ICU just until we get their volume status corrected. But again, if they're hypovolemic, you restore the volume, right? That's the end result, right? Dehydration, right? You got low circulating intravascular volume. You need to replace it. You're going to have the same symptoms you expect in the other shock, in our classic shocks. The SNS is going to fire off, so I get tachycardic and I get cool, clammy extremities. But we will compensate for the first stage or so, but after that we are going to get hypotensive. Okay, so volume lost, replace it, and you can also lose volume if you hemorrhage, right? So you have a hemorrhagic shock of some sorts, right? You have a patient that is a traumatic hemorrhage, right? They got stabbed, right? They are hemorrhaging into their thorax, they're hemorrhaging into their abdomen, they're hemorrhaging out their femoral artery. So these are all major vessel injuries. They have pelvic space can hold about 1 to 2 liters of blood. Your retroperitoneal space, as we mentioned, right? Someone stabs you in the kidneys, can hold about 4 liters, right? 2 2-liter bottles of in Code Red Mountain Dew, right? So they can lose 4 liters of blood immediately, right? Or probably within very, very quickly. So one of the things they teach in trauma is the scalper, right? So scalper is the mnemonic. So the street, they got a external abrasion, external laceration could be a reason for them to be hemorrhaging. They have a chest wound, they have a abdominal wound, a long bone fracture like a femur fracture or a humeral fracture. These things could be a high risk for someone to be bleeding either in that space or bleeding out on the pavement, right? The pelvis, like we mentioned, holds about 1 to 2 liters, and our retroperitoneum holds about 4 liters. So all of these things are sources that we need to get under control in a trauma situation, okay? And again, we don't do traumas here, but you got to recognize that that could be a reason, right? Someone has a hip fracture, they got repaired in the OR, you can lose a lot of blood post-op, right? So it's different kind of traumas. But then there's non-traumatic, which we are used to, right? So we see a lot of GI bleeds, right? A lot of this epistaxis. You got a hemorrhagic pancreatitis, right? Can develop after 7 to 10 days of pancreatitis. You got an aneurysm that might rupture. You got an ectopic pregnancy, as if we had an OB unit, but postpartum hemorrhage is significant as well. All right, and then whenever you have a trauma patient, you want to avoid, or any kind of bleeding patient, I should say, you want to avoid this death triad here, right? This death triad here, so this death triad, you want to avoid, all these are sources for hemorrhage, but you want to avoid any kind of acidosis. And what causes acidosis? Lack of oxygenation. But if they got, like, they broke their leg and they're bleeding out and you stabilize the bleed, why would they develop acidosis? Well, there's, they're still lysine, but they're still oozing blood, let's say, a little bit. Maybe you didn't stabilize it completely, and now they get low blood pressure. And low blood pressure leads to low flow to the tissues. And now you have lactic acid, right? So the blood that you stopped initially, now you have the acidosis. Now your coag cascade, which are proteins, are denatured and they can't work, right? And proteins coag cascade has to work with optimal temperatures. So if you're cold, right, during winter, you get stabbed, it's the worst time to get stabbed, right? So now you can't coagulate great, right? Because your coag cascade is not operational, right? Especially exposure situations, right? So hypothermia. And sorry, over here, hypothermia, and then coagulopathy. That develops when you are bleeding out a lot, right? You bleed out your coag factors, and you're trying to use platelets to clog the hole. But then if it's a big hole, it's going to be using a lot of platelets, a lot of coag factors, and now you don't have enough coag factors or platelets to plug the hole any further. So you're losing these coag factors. You're losing these ways to stabilize your own bleed, right? So we have to sometimes replace that, right? With like FFP or with platelets, for instance, if someone is hemorrhaging. But obviously if someone is hemorrhaging, we got to find and stop the bleed, but also we're going to restore blood volume. We're going to restore PRBCs, restore platelets, and restore FFPs, right? Because as you lose plasma volume, it's going to be a downward spiral. As you lack flow, you're going to develop acidosis. You develop acidosis, your coag cascade can't work. Then now you're losing more volume. Even if it wasn't hemorrhagic, you're still losing volume and you're decreasing flow to the coronaries in the end, and now you're going to start trickling into a cardiogenic shock situation, right? So that's our goal, our causes of hypovolemic shock that we need to try to find the underlying source for, so we can fix it with surgery if we have to, or fix it with volume if they have a volume loss. Okay, so hypovolemic shock, right? So hypovolemic shock, we got ballpark BP. Okay, so ballpark BPs. So you may have heard this myth about your different blood pressures. If I got a carotid pulse, if I feel it there, you got a blood pressure at least 60. If I feel your femoral pulse, you got a blood pressure at least 80, right? So if I feel your radial pulse, you got a pressure of at least 70. This is completely debunked. It's like not true at all. I give you a ballpark, maybe is around that, but it's not, right? So your NIBP is a good one to get information from, but as we know, NIBP will overestimate your blood pressure as you get lower and lower. So this is why I want to request to get a more accurate blood pressure. An arterial line. Arterial line will give you your accurate blood pressure. It'll still be reflected via the aorta and overestimate a little bit, but it's going to be a lot more accurate than an NIBP would. Okay, so there are stages of hypovolemic shock, as we know. We use our little tennis analogy. So you got 1 point, right? You got 1 point right here. That's going to be a 15% loss, right? We got 1 point on someone in tennis, that's 15 love, right? Because love is 0, right? And then you got 2 points, that's 30 points, right? So that's a 30% loss in your blood volume. And you got 40 points, all right? Once you have 3 points on someone, all right? 40 points to 0, and that's a 40% blood loss. And again, we said once you are Losing more than 40%, that's game over, right? You usually are not recovering from this hypovolemic shock, all right? So obviously, blood pressure will be compensated at the beginning. As we mentioned, most shocks are compensated at the beginning, and then it will develop hypotension. So you see the blood pressure starts really dropping in stage 3, stage 4, all right? So the idea here is that we are losing that delivery of oxygen to the patient, right? So the VO2 keeps going up and up and up because they have, let's say, they have this increasing metabolic demands, and we aren't able to deliver the oxygen that we need to, right? So that's going to start plummeting our curve, and we're not going to deliver, our cardiac output is poor because of hypovolemic shock. This is still accurate for septic shock and for other shocks because we're not meeting the body's demand for oxygen, all right? And this reduction in circulatory failure happens because we're not getting oxygen, lactic acid builds up, and now that's more vasodilation and more drop in blood pressure. So we want to try to catch it when we can, right? So stages, again, we got the different guidelines here, but it can change based whether you have blunt trauma versus penetrating trauma. There's different analogies here, right? So you can't really assess if they got 15% or 30% loss, but there's something we want to get a good ballpark about where they're at as far as their heart rate is concerned, as far as the blood pressure is concerned, and we know that they have, there's different comorbidities that put someone at more risk for bleeding than the next person, right? Someone's in aspirin and DAPT therapy, aspirin and Plavix, there'd be a higher risk for bleeding compared to someone who's not, right? So asking, are you on blood thinners, is a good question when someone has hemorrhagic shock, right? If someone has a GI bleed, for instance. So what are the comorbidities might they have? Their liver cirrhosis, they could be at risk, higher risk for bleeding, right? Age, they can't really mount a great SNS response compared to the regular person. And then meds they might be on, right? It's like, oh, they don't got a heart rate elevation, their shock index isn't that bad. Well, what if they're on beta blockers? You're not gonna have a great heart rate elevation if you're on beta blockers, right? So there's different analogies out there as far as what to do. The ABCDF protocol for hemorrhage is in the field, right? They're going to make sure their airway's good, breathing's good, circulation's good, the exposure is controlled. All these things are really kind of situated more towards a trauma course, but it's just something to consider, right? We want to make sure we are getting the circulation restored as best as possible, right? We're getting the volume restored, whether it be packed RBCs or actual fluids, actual crystalloids, right? So hemorrhagic shock treatment. How do you treat someone with hemorrhagic shock? All right, you got to find the cause, right? They got a retroperitoneal hemorrhage. We got to fix that, right? How would you know someone has a retroperitoneal hemorrhage? Yeah, they could have the bruising on the sides, right, with the Cullen sign or the Turner sign, right? So you turn them over, you can see the retroperitoneal hemorrhage. That can happen, or usually doing a CT is going to help us out, right? A CT with contrast, doing a pan scan, you're scanning the whole patient to see where the bleeding might be, right? Initial things, you could provide direct pressure to the wound, right? There's a combat training, but also there's what are called windlass tourniquets that you put around up above the bleed, and you're gonna wrap it around as much as you can and twist it, and the windlass stays in place, provides even tourniquet pressure, and that's going to stop the distal bleed, hopefully, right? So that tourniquet is something that can be used. You're not using the tourniquets from the lab cart. It's like, hey, give me like 5 tourniquets. Someone's bleeding, right? There's the windlass tourniquet is one you want to grab, and they should have one in the trauma bay. That's one that is where it should be at. We've used it before, all right? So there's other different hemostatic dressings that can grab that from the trauma bay or from the OR. All right, with the cellulose, what do they call it? Has a little powder in there that's going to congeal the any kind of bleed. What is it? Hemostatic gauze. Has a brand name, but either way, we're going to reduce any kind of long bone fracture as best we can, right? So that's usually providers going to be doing this for us. And then tourniquets do have a lot of good utility. And invasive things, like if they have a little hemorrhage and they can see it, they go in there, they can suture it up real quick. All right, they got a tamponade. They can tamponade like a ventricular rupture with a Foley catheter balloon. A little bit, it might work, but there's other things. They'll just stick their finger in there. Actually, is going to be better. So they can then take them to OR and fix it right then and there. They can tie out vessels, right? They can have the Reboa devices where they put a huge balloon up into the aorta and just inflate it. That way, everything distal to it's not going to bleed, right? And they usually, they stabilize the patient and they're able to then take it out afterwards, right? Cauterizing, right? IR, they go in IR to find that mesenteric artery that might be bleeding, or find the vein, or sorry, find the artery that's lacerated, and they can embolize it and stop it from further bleeding, right? And then damage control surgery, where they have a huge trauma patient and they have to go and they're going to get the patient worked up and find they're going to open them up, exploratory lap, they're going to open up and try to stabilize everything they can. Okay, so this damage control resuscitation, obviously we're going to prevent further hemorrhage by, hopefully in surgery, but afterwards they got to make sure we're not having any of this death triangle developing, right? Hypothermia shouldn't develop, because what happens with hypothermia, the coag cascade needs optimal temperature to work, so it's not going to work good. So we want to make sure that we are warming the blood we give to the patient. Otherwise, because if you give cold blood to a patient, now they're not going to be able to disassociate their oxygen from the hemoglobin molecule, right? They're not going to be able to do the coag cascade, which is what we want them to be doing, right? So bear hugger should be in place. That way we are keeping them normal temperature, because if you get the temperature too low, then the coag cascade is not going to work. They're not going to be able to achieve hemostasis. All right, so minimize exposure. That's kind of if they're if they come back from the OR, you want to make sure they're nice and warm, because they're exposed for the whole time, but also from the street, you get them up to body temperature. And then monitor temp to make sure it's normothermia, so we're not getting that risk for bleeding. Coagulopathy, what have they been taking beforehand, right? Is there something we can do to reverse it? So what is like the reversal agent for heparin? Protamine, right? What about like Eliquis or apixaban? And Dexinet, right? And like if they take dabigatran, it's kind of been phased out. We have like idarucizumab. So there's other agents we can use, but if you don't know, because those agents cost like 40 to 50K, so if you don't know which agent it is, you usually give what's called PCC, or prothrombin complex concentrate. All right, so PCC is a complex of concentrated prothrombin, and prothrombin is the precursor for thrombin, right? And thrombin is what makes a clot, right? That's the last stage of our coag cascade. We make those thrombin, we make this clot out of thrombin and platelets and fibrin, and all these things are going to, maintain a clot or make a clot. So we give PCC to replace anything they might be missing. And if you're giving these medications, the anticoagulants, they are blocking the coag cascade in some fashion, or you're taking antiplatelets, they're blocking it in some fashion, right? So permissive hypotension is another thing to consider. So I didn't mention acidosis, but we talked about acidosis. They are going to, you want to make sure the pH is great. Otherwise, if the pH is really, really low, it could be because they're really, really hypotensive or hypoperfused. So we might need to restore that with like bicarb infusions, not bicarb pushes, but bicarb infusions. We might need to, correct on the ventilator to, blow off some CO2 so we can get a pH in the optimal range for our coag cascade to work. And then in the meantime, we're going to make sure that we have permissive hypotension, right? Because if you're bleeding out, you're going to bleed out more if your blood pressure is 160 compared to 100, right? So we want the blood pressure all the way down to 80 to 100, so we stop the actual, squirting out of blood, right? So that's the goal with permissive hypotension, 80 to 100. We're dropping it all the way down. And then we'll learn a thing or two from the trauma protocol, where they don't give more than 1.5 liters of fluids, right? If you're giving 2 liters, that's pretty much too much fluid that you're giving the patient, too much normal saline. We know normal saline causes acidosis, that's not great. So LR is usually go-to fluid we give. And you give those 2 liters, that's gonna start diluting out the blood. And that's gonna dilute out the clotting factors. So now the clotting factors can't reach each other and they can't clot. So the best thing to give to these patients is what? As blood, right? So we usually call it massive transfusion protocol. That's usually called, especially when your blood pressure is less than 90. Before that, you just give uncross-matched units like ONEG. But other than that, you're going to give blood to the patient, and it needs to be given somehow, whether the blood pressure is low or not low. Right then and there, you're not going to have time to wait for it to be typing cross downstairs to get the right unit, send someone down to pick it up. Usually it's right there in a fridge in the trauma bay, or it's brought up in a little cooler when we need uncross-matched units, right? And of course, during the MTP, you do use uncross-matched units as well until 30 minutes elapses, and then you can find out what kind of blood they are and give the blood that you need. So it's given usually 1 to 1 to 1, meaning that we give 1 platelet, 1 FFP, and 1 packed RBC That's what we're giving the patient. That's the best thing. Because again, when you bleed, you don't just bleed out PRBCs and not platelets and not coags, right? So you want to replace what's being lost. So it's a simple thing, replacing what's coming out. So replacing the PRBCs, the platelets, and the FFP, which is the plasma, right? So we replace it all 1 to 1 to 1, but again, that's not always doable because not everybody donates blood in America, and there's not a lot of supply. It's in short supply. So usually do like 4 2 to 1. So 4 PRBCs, 2 FFPs, and 1 platelet, right? So we might have like 2 platelets on site right now because we're not a trauma hospital. So we have like 2 platelets on site. So once we use those 2 or use the first one, they're calling to find platelets for someone else, right? And that's to come from LA, and it takes at least 40 to 60 minutes to arrive. So we got to plan ahead. And then when you give all these blood products, they could cause if they're not warmed up, they're going to be cold and cause more coagulopathy. The other thing is they have a preservative in it, and the preservative can bind what electrolyte? Calcium. Good. So calcium can be bound, and now you're hypocalcemic, right? And now that can lead to hypotension in of itself, and also calcium is also important in how else? If you look at the coag cascade and you filter in calcium, it's used at least like 10 steps, all right? So if you don't have calcium, you can't coag. You can't do a coag cascade. So we're going to make sure we're replacing calcium. Usually after 2 units, but definitely after 4 units. And we're definitely checking labs after 4 units to make sure we are not, we're checking our work, make sure the hemoglobin is stabilizing, also checking to make sure the calcium is not getting too low. Okay, TXA or tranexamic acid can be used sometimes with a hemorrhage. All right, it's a great thing that promotes the coag cascade. It's a procoagulant, right? So it's the opposite of a thrombolytic, right? And then we talked about replacing the clotting factors. If we know they're taking something that's going to be stopping the coag cascade or stopping platelets, we can give PCC to reverse like a warfarin or reverse a heparin or reverse a apixaban, a 10A inhibitor. Okay, and we talked about damage control surgery. It might even have to be done again to make sure that they are, that everything is stabilizing. So checking drains, make sure there's not too much output in the drains is another key thing. Other points here are to make sure that you're giving blood via the best lumen possible. So short and thick does the trick is the way to think about it. So you want to make sure it's a nice short catheter and it's thick, right? The lumen is bigger, right? So an 18 gauge or 16 gauge is bigger than a 20 gauge, right? So a PICC line, as you notice, is about, it's about very, very small, right? It might be 18 gauge, but look how long it is, right? It has all that resistance. If you know your physics, all that resistance is going to be get in the way of giving blood products or fluid resuscitation. So the best thing to do is put 2 18 gauges in or 2 16 gauges if you're fancy, right? An IO is about 18 to 20 gauge, and that's really short catheter as well. So interosseous can be used as well. They get great flow rates. So you can see the flow rates over here, about 105 mLs per minute. That's per minute we're giving to the patient, right? Compared to like a PICC line, we'll be giving about, what do you say, down here, it's going to be about 15 mLs per minute. That's not a lot of flow, right, compared to 100. And if you look at like a triple lumen catheter, like you think, oh, I got central access, perfect, right? You see that's just about the same as a peripheral IV. If you were to do a 16 gauge, it'd be better than a triple lumen catheter. But we have other size triple lumen catheters. We have the 7 French, which is standard, or we can beef it up with like an introducer sheath or a huge catheter, which are like 12 French catheters. And those are really going to put a lot of flow into the patient. Okay, and you want like a direct shot as much as possible. You don't want to be putting like little enclaves on, right? The little claves that create negative pressure. You want to like disconnect all that and make sure it's all going in nice and uninterrupted. Okay, so maintain euthermia, make sure electrolytes are good, especially calcium, avoid acidosis, use physiological fluid. What's a physiological fluid? Be something like not NS, right? Because NS is abnormal saline. So you want to make sure you're using like LR is great. If they're acidotic, you can use like a bicarb drip to help resuscitate, right? Correct coagulopathy if they have it, especially if they have a history of taking anticoagulants. And then TXA can be given usually within 3 hours, especially like in OB world, they'll give TXA, and especially in trauma world, they'll give TXA.